invitation and thank Tirimo for having supported this session. So, Dr. Ishihara, without any further delay, I just would like to ask you to start your lecture entitled How Do I Manage Complications in the Cath Lab? Dr. Ishihara.
Thank you so much, Dr. Gamla. So I'm so glad to join this great conference this year. And so unfortunately, we know our COVID pandemic so serious, so that I couldn't visit Maghreb countries or African countries. But every year I visit Tunisia and Morocco and any countries to do workshop. So it's very happy to work with you together. So can you see the slide?
Yes, we see the slides.
It's okay. Yes. Okay. So let me start. This is my COI. So first of all, so I'm a Japanese doctor, so it's very far from your country. So I a little bit introduction of our hospital. Our hospital is so Sakai City, Osaka in Japan, and also in Osaka. Osaka is almost a meet in Japan, and also this is our new hospital. And so there is a World Heritage, very large tomb near our hospital, like this. So I said I did many CTO workshops. I treated so many patients in Tunisia and Morocco. So maybe after the COVID pandemic, I hope to work with you again, and I want to contribute more educational conference and workshop in your countries. So today my topic is complications. But as you know, there are so many kinds of complications. I can't talk all of those in 30 minutes. So that today I focus on one topic, coronary perforation, and also I want to show some cases, not perforation, but so for example bifurcation, and so interesting case. So this is one very educational and also interesting case. When I came back to cath lab after outpatient clinic, so our younger colleague, so young fellow, was performing PCI. So this is a bifurcation lesion and just OCL lesion of OM branch circumflex, like this. And she was a little bit old, but enough active patient, and she has chest pain. So that my younger colleague performed PCI. So using 2.0 millimeter balloon dilatation and put the stent from ostial circumflex to OM branch. After that, he tried to perform kissing balloon, so that another guide wire was very close to main circumflex branch, and he performed kissing balloon technique, OM branch and also circumflex. This is the angio after kissing balloon. Result looks very nice. Is it okay? So, but just I came back to the cath lab. This movie is moving. I know in your countries it is sometimes difficult to use imaging device because of economical issue. I know. But just imagine what is happening in this case. So this is a stent we can see very good opposed and also well dilated. And around here, we can see the bifurcation here. This is a OM branch and also main circumflex. Do you understand what's happening? Like this. I I saw this picture and what I doing? So my colleague said, "Oh, just finished now." But this movie was shown repeatedly. What happened? So I will show the schema figure. He put the stand to main branch. So maybe in this case, put the stand to OM branch. And after he just recross the wire, but wire is from outside to side branch. And he performed kissing barrel. It is a truly kissing barrel technique? No. So after that, of course, stent is very mal-approached, not attached. So in this kind of image, we can see this is the side branch from 12 o'clock. And also, stent is very mal-approached like this. There is a very large space outside of the stent strap. So it's a very important issue. Of course, and so final, not final, but angio was very nice, but stent result is not nice. So that in this in this point, I said him to do dilation of proximal part again, and also recross the guide wire with using crusade. So maybe in your countries, it might be available dual lumen catheter. Kaneka or some other company is producing dual lumen catheter, so that the wire is from stent strap to side branch. And after checking that, once again dilate and also kissing balloon. So this is a real kissing balloon. Putting stent and stent is not opposed. So that first of all we should do pot. After that, we should recross the wire to the side branch, and after that cavity. This is a real kissing balloon technique. Maybe it is very easy understanding for expert doctors, but for young doctors, some don't understand how to do kissing balloon or how to do recross of the guide wire from stent strap. It's very important. Uh, so this is a final angel. It's very nice, and also I will show the proximal stent is very nicely opposed after the real kissing balloon technique. So for optimal bifurcation PCI, to and also to avoid this kind of trouble. So if you can use the imaging device, IBUS or something, it is important not to use IBUS, but important thing is to check the image carefully and use the information. But it's very important, especially large bifurcation lesion, including left main bifurcation. And also POT, so proximal optimization is important, but maybe as you know, it's a very popular thing. And also, we sometimes use dual lumen catheter when we can. It is difficult to recross the wire from the stent strap. These are the some options. Don't perform kissing balloon technique like this, and also maybe you can imagine without IBUS or without OCT, but wire is from strap or wire is going beside outside the strap. So this kind of imagine and understanding is very important. This is my educational message and to teach for young fellows. I will show another bifurcation case. The patient was 71 years old male, and no ST change and a little bit heart failure. And the coronary angio showed. severe left main bifurcation lesion, truly bifurcation lesion like this. And also this is a aerial caudal view, and also this is a spider view. Right coronary is almost okay, and also ejection fraction is it's also nice. So we discussed bypass surgery or PCI, but patient strongly refused bypass surgery, so that we performed PCI. And this is a comparison. So 2 years ago and also current CSD, very so progressing disease of left main bifurcation. So for this lesion, we performed PCI. The system is 6 French and also from from femoral. In this case, dilate, circumflex, and also LAD with 2.5 baron. And after that, we check the OCT, imaging device. But it's not so important, I think. So after checking imaging, it's not so important. So after checking the image, we put the stent. This is the Altimaster stent 2.75 for circumflex. Just from just ostium of circumflex like this. And so bifurcation is relatively, so bifurcation angle is large. So I choose to, for this case, T stenting. And also, additionally, I put the stent from Altimaster 3.5 stent from left main to LAD, like this. After putting 2 stents, I performed the pot with 4.5 large balloon at left main bifurcation, so left main, proximal left main, and like this. And after that, recross the wire to circumflex and dilate the stent slot, and also performed kissing balloon like this. So this is final image. Well, left main is also nice. And we can see the 3D OCT if we use this kind of imaging device. So this is the ostium of circumflex, very nicely open and without stent strap on the ostium of circumflex. This is a final result, very nicely treated. And 1 year follow-up, also very nice. This was very progressive lesion, but the patient have no restenosis, including circumflex ostium, very nice. So as you know, recross point of guide wire is very important, as you know. If guide wire goes to circumflex or bifurcate, so side branch, from distal stent strut, after kissing balloon or after dilatation of the stent strut. So like this, stent strut is attached to opposite side of the carina, like this, so that we can get so wide open of side branch, as you know. So so that many doctors say when we cross the wire, we should we try to get distal strut to open the side branch very well. It is very understandable. And also I show the OCT image, but without OCT image, we can understand and we can try to understand this schema. Maybe very expert doctors understand, but younger fellows, some not understanding. So that it's also very important. Without imaging device, without IVAS, but in our brain, in our imaging, we should think about this kind of schema. And so, as you know, there are many PCI techniques for bifurcation regions, uh, main branch and also side branch and pilot stent and DK clash and any kind of stenting. And I was for treating bifurcation lesion, especially left main. Of course, I was OCT effective in some situation, effective, but it's very expensive. When I visit Tunisia, when I visit Morocco, and when I visit many Asian countries, sometimes I can use, but most of the cases I can't use IBAS because of economical reasons. So that even we can't use IBAS or OCT, but we should understand, we can imagine optimal stent dilatation. So it means pot technique, and also suitable guide wire recross for optimal cavity. It's very, very important to avoid any kind of trouble. And for this kind of left main bifurcation, we should understand how much we can dilate and how much the side branch can be open. So Ultimata stent has a very large lumen. We can dilate very large, up to 5.8 millimeter. So it's very easy to oppose even large left main bifurcation without break the stent. And over expansion capacity, so how much expand is up to 5.8 millimeter. And also we can dilate side branch very largely because the two link design of this stent. And also like this side branch access, if we get the distal stent strut, we can open up the stent strut like this very widely. So that this stent is flexibility, very flexible, and also side branch opening nice and good expansion and long-term efficacy. Also confident. So from today, I was sponsored by Termo, so that please understand I talk about that. So this is first part, and the next part is coronary perforation. So I'll talk about management of severe coronary perforation. As you know, if we face very severe perforation, we should do in some situation long time balloon inflation to stop bleeding and get hemostasis. In some countries, maybe perfusion balloon catheter might be available, but maybe most of countries not available. And also, heparin half reverse can be considered. And also, if we need, we should do pericardial synthesis in case of tamponade. And also, covered stent might be effective. And the final option is, as you know, surgical operation. And this case is perforation case, 73 years old female, and 6 months after, so STEMI, the LAD lesion is progressive. So that I put the drug rating stent. This was a very old case. In this time I used Taxa stent. And after putting stent like this, the stent expansion small part is not enough. So that I performed post dilation up to 24 atmosphere. So balloon indentation disappeared, but after dilation, coronary perforation, severe perforation occurred. It's a serious situation. Maybe she will soon be temporary and cardiogenic shock. So that I inserted the balloon catheter again. But if during balloon inflation, so the patient ST elevation is severe, and also she complained chest pain. So that I try to perfuse distal part with patient blood. So this is a perforation site, and I put the balloon here, and so inflate the balloon so that distal part is no blood flow, so it means ischemia. So that I inserted microcatheter besides the balloon catheter, and also I inject the patient arterial blood via this microcatheter, so that with getting balloon long-time inflation, I can perfuse distal part. So during this technique, so ST elevation is getting better, and so very long time balloon inflation could achieve. So after 20 minutes balloon dilatation, bleeding stopped, and no cardiac effusion. So after this case, I tested. So I made examinations so many times. Of course, not in the patient, but so in vitro examination. So after that, this is a schema of this technique, microcatheter distal perfusion. So first of all, after perforation, insert the guide wire and also balloon catheter. And after inflation, distal part is no blood flow, but perforation is controlled. In this situation, insert wire and also microcatheter just in front of the balloon catheter, and quickly deflate and also insert the microcatheter distally and inflate again, so that bleeding controlled again, and after retrieve the guide wire and also inject the patient arterial blood. It was taken from another part, femoral sheath or additional radial sheath, any kind of. Okay, so this is the image. This is the balloon catheter. So inflating to get hemostasis, and this is another fine cross microcatheter. So it is so possible to insert both in 1/6 guiding catheter, and this is another sheath, and also we can get arterial blood from here, and we connect with small tube and stopcock like this. We need this kind of short tube and also stopcock, and with small syringe we can do pumping like this. So this is a summary. Microcatheter distal perfusion technique is very cheap way. We need only one microcatheter, and very useful when long inflation is needed. Not only perforation, but also, for example, thrombus happens a lot, and any kind of situation. If it is not effective enough to stop bleeding, but we can consider during this technique how to treat any other therapeutic options, surgical, cover stent, or something during this technique. So this is final my message. Complication comes suddenly, and we should learn bailout options from others. Thank you for your attention.
Dr. Ishihara, thank you so much. That was very clear, very useful, rich lessons. Thank you so much. Dr. Ben Ahmed, any question, Dr. Ishihara?
You have to activate your.
I have two comments for Dr. Ishihara. First of all, as you mentioned in our country, coronary imaging, IVIS, and OCT are not very available. But I think that reosment technique like stent boost, or clear view are underused to assess the open cell in the side branch. And to be sure that the wire is in the good position when we cross the struts to the side branch. One tips and tricks, I think, if we have not OCT or IBUS, we can avoid to be very close to the gilded wire. We take the wire to a cross in the side branch, and if we try to be in the distal struts for the side branch, we try to avoid to be very close the two wires, the giant one and the wire. We try to be not very close. It's can help to be sure that we cross in the best struts. What another question? Another comments for the case in which you show us the left main bifurcation lesion. It's a huge left main, a complex lesion, distal lesion, 111 Medina. But in your practice, you use 6 French for this kind of left main, or 7 French to be more comfortable in this kind of lesion.
Yes, thank you for that nice comment and the question. So first one, without IVAS or without CT, we can, for example, use for example, stent boost or angio-guided recrossing, and it's very important. I also show the stent boost image, recrossing or stent post dilatation. It's very important, and as I mentioned, without IVAS, but this kind of schema is easy to understand and easy to get in any kind of conference. So that just we can imagine, and we perform without IVAS. So it's very important, and stent boost is very nice. And your second question is for left main bifurcation, very complex situation, 6 French or 7 French. It's very important, but in some part difficult question, because in Japan we usually use 7 French because we can insert 7 French guiding catheter from radial. We prefer radial. Maybe all of you also prefer radial approach, but sometimes 7 French guiding catheter is difficult to insert from radial. But in Japan, we can use glide C cylinder. We can insert 7 French from radial. So it's very nice one from Telmo. But in some countries available, but I know in some countries not available. But so that it is easy to insert 7 French. And we have many kind of shape, upwards and backup type and any kind of 7 French. But in some countries, 7 French are available, but so the guiding catheter shape is somehow limited. So that in such kind of situation, I think 6 French is available, but I prefer radial. That's my answer. Okay.
All right, Dr. Ishihara, thank you so much. We wish we could have more time to discuss with you further, because you have many lessons to teach us. But unfortunately, we're running out of time, and we have an important session now. It's called the innovation session with techniques you have never seen before. So you might be able to join us, but not through this link. You have to have the general link of the Congress. Thank you very much again. And thank you for the panelists for having taken the time to share with us this session. And let's move to the next one. Thank you.